The words hit me like a slap across the face. Get me a real doctor. I stood at the entrance to Bay 7, clipboard in hand, white coat still stiff and new, the weight of my stethoscope around my neck feeling heavier than it should. The man on the gurney looked at me with undisguised contempt, his arms crossed over his chest, his jaw set in defiance. "Sir, I am a doctor," I said, keeping my voice level despite the heat rising in my cheeks. "I'm Dr. Noah Reyes, and I'll be—" "You look like you're 12 years old." He cut me off, his voice sharp and dismissive. "How long you been out of medical school? A week? A month? I didn't come to this hospital to be some rookie's practice dummy." It was 6:23 p.m. on a Tuesday in late November, and St. Halstead Hospital's emergency department was operating at controlled chaos, the usual symphony of beeping monitors, urgent conversations, and the underlying current of human suffering that never quite went away. I was 4 months into my residency, still fighting the imposter syndrome that whispered I didn't belong here, that I wasn't ready, that everyone could see through me. And now this man, according to his chart, Thomas Garrett, age 47, was saying out loud what my inner critic whispered every day. "Mr. Garrett," I tried again, "I understand you're concerned, but I assure you I'm qualified to— I want Dr. Keller, or Dr. Harrison, or literally anyone who's been doing this longer than a few months." He looked past me, scanning the emergency department. "Where's the attending? Get them. Now." Sarah, the nurse who'd been setting up his IV, gave me a sympathetic look. She'd seen this before, patients who took one look at my young face and assumed incompetence. It came with the territory of being a first-year resident who looked even younger than his 27 years. The emergency department stretched behind me, a maze of curtained bays and rushing personnel. In Bay 3, a child wailed while his mother tried to comfort him. In Bay 5, an elderly man's heart monitor beeped irregularly. The fluorescent lights overhead cast everything in a harsh, unflattering glow that made everyone look sicker than they probably were. "I'll page Dr. Keller," Sarah said quietly, her voice kind. "Thank you," Thomas said, his tone softening slightly when addressing her. Then, looking back at me, "No offense, kid, but this is my life we're talking about. I need someone who knows what they're doing." I wanted to defend myself, to list my credentials, to explain that I'd graduated top of my class from a prestigious medical school, that I'd scored in the 99th percentile on my board examinations, that I'd chosen emergency medicine specifically because I thrived under pressure and loved the intellectual challenge of undifferentiated complaints. But what came out was simply, "I understand." And I did understand. Fear makes people cruel. Pain makes them desperate. And the emergency department was where fear and pain converged, stripping away social niceties and leaving raw human emotion exposed like a nerve. I stepped back from the bay, my face burning with humiliation that I hoped wasn't visible under the harsh lights, and nearly collided with Dr. Miriam Keller. "Problem, Dr. Reyes?" she asked, her silver hair pulled back in its usual tight bun, her reading glasses hanging from a chain around her neck. She had that look, the one that said she'd already assessed the situation and was 3 steps ahead. "The patient in Bay 7 is requesting a more experienced physician," I said, trying to keep the emotion out of my voice and failing slightly. She glanced past me at Thomas Garrett, then back at me, her gray eyes sharp and evaluating. "And you're going to let him dictate his care?" I thought, "What did I tell you on your first day, Dr. Reyes?" I knew exactly what she'd said, because I'd written it down in the small notebook I kept in my pocket alongside my clinical references and drug dosing charts. That patients don't get to choose their doctor in the emergency department. They get whoever's on shift. Exactly. So unless there's a medical reason why you can't treat Mr. Garrett, some conflict of interest or area outside your scope of practice, you're his doctor. Understood? "Yes, ma'am." "Good. Now brief me on the case." I pulled up his information on my tablet, grateful for something concrete to focus on, something that had clear answers and didn't make me question my worth. Thomas Garrett, 47-year-old male, presenting with severe abdominal pain. Started approximately 6 hours ago, describes it as sharp and constant, localized to the right lower quadrant. Denies fever, but reports nausea and decreased appetite over the past 2 days. No vomiting, no diarrhea, no urinary symptoms. Differential diagnosis? Appendicitis is at the top of my list, but also considering kidney stones, diverticulitis, or possibly a GI obstruction. Less likely but possible would be testicular torsion with referred pain, psoas abscess, or even atypical presentation of something vascular. What's his surgical history? I scanned the chart more carefully. None documented. No previous hospitalizations, no chronic conditions, no regular medications. He's been essentially healthy until now, according to his intake form. Vital signs? Blood pressure 138/85, heart rate 94, temperature 99.1, respiratory rate 18, oxygen saturation 98% on room air. Everything's within normal limits except for the slight temperature elevation, which could indicate early infection. Dr. Keller nodded, a slight movement that could have meant approval or could have meant nothing at all. Sounds like straightforward appendicitis. But you need to examine him, order labs, and get imaging to confirm. Think you can handle that, or should I send in a real doctor? The edge in her voice told me this was a test. Not of my medical knowledge, she knew I had that, but of my ability to handle the emotional challenges that came with the job. The patient who refused care from residents. The family member who demanded to speak only to attendings. The colleague who questioned your judgment. Medicine was as much about managing people as it was about managing disease. I can handle it, I said, and this time my voice was steadier. Then prove it. And Dr. Reyes? She paused. Don't let his fear make you doubt yourself. You earned your white coat. Act like it. She walked away, her footsteps purposeful on the linoleum floor, leaving me standing outside Bay 7 gathering my courage like armor. I took a deep breath, squared my shoulders in a gesture my mother used to do before difficult conversations, and walked back in. Thomas Garrett looked up, his expression shifting from hope to disappointment when he saw me instead of Dr. Keller. You're kidding me, he muttered, his voice laden with resignation. Mr. Garrett, I'm going to examine you now, I said, my voice firmer than before, channeling every attending physician I'd ever observed. I understand you'd prefer a more senior physician, but Dr. Keller has reviewed your case and agrees with my assessment plan. So we can either work together to figure out what's causing your pain, or you can continue being difficult and delay your own diagnosis. Your choice. He blinked, surprised by my directness, his arms uncrossed slightly. Then, grudgingly, fine, do your exam. Small victory, but I'd take it. I washed my hands at the sink in the corner, the water scalding hot the way I'd been taught, scrubbing for the full 15 seconds while mentally reviewing anatomy. Right lower quadrant pain, McBurney's point, psoas sign, obturator sign, Rovsing's sign. All the tests I'd memorized in medical school and practiced on standardized patients who didn't actually have appendicitis. I pulled on gloves with a snap that sounded more confident than I felt and approached the bedside. I need you to lie flat and relax your abdominal muscles as much as possible. I know it hurts, but I'll be as gentle as I can. He complied, wincing as he shifted position on the uncomfortable gurney. I started with general inspection. His abdomen wasn't distended. No visible masses or pulsations. No surgical scars to indicate previous abdominal procedures. I placed my stethoscope on his abdomen, listening for bowel sounds. They were present but diminished, consistent with peritoneal irritation. Then I began palpation, starting in areas away from the pain, watching his face for signs of discomfort. The upper quadrants were soft, non-tender. Left lower quadrant, soft, non-tender. But when my hands reached his right lower abdomen, specifically at McBurney's point, the spot 1/3 of the way from the anterior superior iliac spine to the umbilicus, he gasped sharply and his entire body tensed. That's it, he said through gritted teeth, sweat beading on his forehead. Right there. That's exactly where it hurts. I continued the exam methodically, running through the specialized tests. Rebound tenderness, positive. I pressed deeply, then released quickly, and he winced again as the pain intensified with the release. Rovsing's sign. I palpated the left lower quadrant, and he reported pain on the right side. Positive. Psoas sign. I had him flex his right hip against resistance, and the movement caused significant discomfort. Also positive. Everything pointed toward appendicitis. Textbook presentation. Classic signs. I'm going to order some blood work and a CT scan, I said, stripping off my gloves and disposing of them in the red biohazard container. The blood work will tell us if there's an infection. We're looking for elevated white blood cells and inflammatory markers. The CT will show us if your appendix is inflamed and help us rule out other causes. And if it is appendicitis, then you'll need surgery, appendectomy. It's one of the most common surgical procedures. We do dozens of them here every week. Usually laparoscopic these days, which means small incisions, less scarring, faster recovery time. Most patients go home in a day or two. How soon would the surgery be? Depends on how inflamed the appendix is and whether it's at risk of rupturing. Could be tonight, could be tomorrow morning. But we won't know the urgency until we see the imaging. He nodded, some of the hostility draining from his expression like air from a punctured tire. Pain had a way of making people focus on what actually mattered. Okay, do what you need to do. Sarah returned with the phlebotomy cart, its wheels squeaking slightly as she maneuvered it beside the bed. She was efficient, drawing multiple tubes of blood while Thomas looked away. Even tough guys didn't like watching the needle go in. While she worked, I put in orders through the computer system. Complete blood count with differential comprehensive metabolic panel, C-reactive protein, urinalysis, and a CT scan of the abdomen and pelvis with IV and oral contrast. The CT prep will take about 30 to 45 minutes, Sarah explained to Thomas as she labeled the blood tubes with practiced efficiency. You'll need to drink this contrast solution, about 450 milliliters total. I know it doesn't taste great, but it helps us see your organs more clearly on the scan. We've mixed it with a little crystal light to make it more palatable. Whatever it takes, he said, taking the bottle from her with a grimace as he read the volume marking. I was updating his chart in the computer system, documenting my physical exam findings with precise medical terminology, when my pager buzzed against my hip. Dr. Keller, asking me to meet her in the physician's lounge. When I arrived, she was pouring coffee from the perpetually stale pot that no one ever cleaned but everyone drank from anyway. The lounge was a small room with mismatched furniture donated from various hospital departments over the years, outdated medical journals stacked in corners gathering dust, and a lingering smell of microwaved food and burnt popcorn that never quite dissipated no matter how many air fresheners people brought in. "Sit," she said, gesturing to one of the threadbare chairs. I sat, the springs creaking beneath me in protest. How'd it go this time? He let me examine him. Significant tenderness at McBurney's point, positive rebound, positive Rovsing sign, positive psoas sign, no rigidity or guarding yet, but all the classic signs point to acute appendicitis. Labs are pending, CT is scheduled, I'm confident in the diagnosis. And how are you feeling about it? The question caught me off guard. Dr. Keller wasn't known for checking in on residents' emotional states. She was brilliant, demanding, and scrupulously fair, but not particularly warm or nurturing. Her teaching style was more sink or swim than hand-holding. I'm fine, I said automatically. Dr. Reyes, I've been doing this for 30 years. I can tell when someone's rattled. His comments got to you. There was no point in lying to her. She'd see through it instantly. Yeah, they did. Good. Good? If comments like that didn't bother you, I'd worry about you. It would mean you're either arrogant or you've lost your empathy. Arrogance gets patients killed because you stop double-checking yourself. And loss of empathy means you've burned out, which means you're not far behind from making serious mistakes. She took a sip of her coffee, grimaced at the taste like she always did, but took another sip anyway. But you can't let it paralyze you or make you second-guess every clinical decision. You need to develop a thick skin while maintaining a soft heart. That's the balance every good physician has to find. How do I do that? How do I learn not to take it personally when patients question whether I'm competent enough to treat them? Practice, experience, making mistakes and learning from them without letting the mistakes destroy your confidence. And remembering that patients like Mr. Garrett aren't really angry at you. They're angry at their situation. The pain, the fear, the loss of control that comes with being sick. You're just the convenient target because you're there and you look young. That doesn't make it feel better in the moment. I know, but it's the truth and understanding it helps. She set down her coffee cup on a magazine someone had left on the side table. Here's what I want you to understand, Dr. Reyes. You're going to encounter a lot of Thomas Garretts in your career. Patients who doubt you because of your age, your appearance, your gender, your accent, whatever arbitrary criterion they've decided matters. And some of them will be right to doubt you. You're still learning. You will make mistakes. You don't have the pattern recognition that comes with decades of experience, but most of them will be wrong. Most of the time, you'll be exactly the doctor they need, with exactly the skills required to help them. Your job is to prove it with your actions, not your words. Show them through excellent care, not through defensive arguments about your qualifications. Yes, ma'am. Now get back to your patient. Check on him while he's drinking that contrast. And Dr. Reyes? She paused, looking at me with an expression I couldn't quite read. Trust your instincts. You've got good clinical judgment. That's not something that can be taught. You either have it or you don't. Don't let anyone make you doubt that gift. I returned to the emergency department feeling slightly steadier, like a ship that had found its keel again after rough waters. The validation from Dr. Keller, even delivered in her characteristic no-nonsense style, helped quiet some of the self-doubt that had been screaming since Thomas's initial rejection. The emergency department continued its relentless pace around me, indifferent to any individual drama. In Bay 3, a college student with a sprained ankle was getting fitted for crutches and instructions on Rice protocol. In Bay 5, an elderly woman was being worked up for chest pain that looked increasingly like severe GERD rather than cardiac issues. Her EKG was normal, and she was describing the pain as burning and worse after eating. In Bay 9, a construction worker was having a nail removed from his foot. He'd stepped on it when it penetrated through his boot, miraculously missing all the major structures, but still requiring thorough irrigation, antibiotics, and a tetanus booster. Each patient was a puzzle, a story, a crisis that needed solving. And I was responsible for all of them, for making sure nothing was missed, no diagnosis overlooked, no complication allowed to develop because I wasn't vigilant enough. The weight of that responsibility sometimes felt crushing. Thomas Garrett's labs came back 43 minutes later. I pulled them up on the computer, Sarah standing beside me as we reviewed the results together. She'd been an emergency department nurse for 8 years and had seen thousands of labs. She could often predict abnormalities before the results even came back. White blood cell count, 16,200 cells per microliter, elevated significantly above the normal range of 4,000 to 11,000. This indicated infection or significant inflammation. Neutrophils, 87%, also elevated, suggesting bacterial infection rather than viral. C-reactive protein, 45 mg/L, significantly elevated above the normal value of less than 10, another marker of inflammation and infection. Everything else, electrolytes, kidney function, liver enzymes, glucose, was within normal limits. Classic appendicitis labs, Sarah said, nodding with the confidence of experience. I'd bet money on it. I've seen this pattern hundreds of times. Let's see what the CT shows, I said, not wanting to commit fully until I had imaging confirmation. Labs supported appendicitis, but they weren't specific. Other conditions could cause similar elevations. The CT scan was scheduled for 8:15 p.m., which gave me time to check on my other patients. I updated the college student's discharge instructions, conferring with orthopedics about appropriate follow-up timeline. I reviewed the cardiac workup on the elderly woman with her, explaining that her heart looked healthy, and this was likely severe acid reflux that would respond to medication and lifestyle changes. I supervised the wound care on the construction worker, teaching a third-year medical student the proper technique for high-pressure irrigation and the principles of delayed primary closure versus immediate closure for contaminated wounds. This was the rhythm of emergency medicine that I was slowly learning to navigate, juggling multiple cases simultaneously, triaging by acuity, keeping dozens of details organized in my mind while staying alert for the unexpected deterioration or the subtle finding that changed everything. Sarah found me at the nurse's station around 8:00 p.m., just as I was finishing documentation on the construction worker's wound care. Your appendicitis patient is back from CT. Images should be up in about 5 minutes. Also, he asked if you'd stop by when you have a chance. I think he wants to apologize properly. He doesn't need to apologize. He was in pain. I know, but I think he needs to say it anyway. For himself, not for you. I walked to Bay 7, my shoes squeaking slightly on the newly mopped floor. Thomas was lying back against the raised bed, looking exhausted and uncomfortable. The contrast he'd drunk had passed through his system enough for adequate scanning, but the large volume of fluid combined with his nausea had left him feeling bloated and miserable. "Dr. Reyes," he said when he saw me, attempting to sit up slightly and wincing at the movement. "Thanks for coming by. How are you feeling?" Like I swallowed a bucket of chalk mixed with artificial fruit flavoring and someone stabbing me in the gut with a hot poker. Other than that, absolutely fantastic. Despite everything that had happened, I smiled. Patients who could make jokes, even dark ones, were usually not as sick as they feared. The contrast does have that effect. The nausea should pass in another hour or so. The scan itself was quick. You did well. Listen, I wanted to say something. He shifted uncomfortably, not quite meeting my eyes. What I said earlier, about wanting a real doctor, about you looking too young, that was completely out of line. I was in pain and scared, and I took it out on you because you were there and you looked like an easy target. That wasn't fair, and it wasn't right. It's okay. I understand. Emergency rooms bring out the worst in people sometimes. No, it's not okay. He finally looked at me directly. You're trying to help me, probably working a 12-hour shift on your feet the whole time, and I treated you like you didn't deserve to be here. I was an asshole, and I'm sorry. The sincerity in his voice was disarming. I appreciate that, and apology accepted. But honestly, it's more common than you'd think. A lot of patients are skeptical when they see how young I look. That's their problem, not yours. He paused. I have a son about your age. 26, just finished law school. Smart kid, works hard, but he looks even younger than he is. Gets mistaken for an undergrad all the time. If someone treated him the way I treated you, if they dismissed him because of how he looked rather than what he knew, I'd be furious. So I'm sorry, really sorry. The comparison to his son added another layer of meaning to the apology. Thank you, Thomas. That means a lot. Now let's focus on figuring out what's going on with your abdomen and getting you feeling better. When will the CT results be back? Any minute now. The radiologist is reviewing them, and then I'll be able to see the images. I'll come find you as soon as I've looked at everything. And you'll tell me straight, whatever it is? I'll tell you exactly what I see and what it means. I promise. I left him and returned to the imaging station, where the CT scans were just populating on the screen. The computer system loaded them slice by slice, each cross-sectional image appearing in sequence. I pulled them up in the viewing software, scrolling through the axial slices systematically, looking for the telltale signs of appendicitis I'd been taught to recognize, but something was wrong. The appendix looked normal. Completely, unequivocally normal. No dilation beyond the normal 6mm diameter. No wall thickening. No periappendiceal fat stranding that would indicate inflammation extending beyond the organ. No fluid collections. No enhancement with the IV contrast that would suggest inflammation. I frowned, scrolling through the images again more slowly. Maybe I'd missed it. Maybe the inflammation was subtle, or maybe the appendix was retrocecal, tucked behind the cecum, and harder to visualize in its entirety. But no, the appendix was visible in multiple slices, and it was definitively, unequivocally normal by every radiological criterion I'd been taught. I sat back in the chair, confused and frustrated. Everything had pointed toward appendicitis. The classic right lower quadrant pain, the physical exam findings that were textbook positive, the elevated inflammatory markers. But the imaging, the gold standard for diagnosis that was supposed to confirm my clinical suspicion, was completely negative. My first thought was that I'd been wrong, that I'd missed something, misinterpreted the exam, jumped to conclusions. My second thought was that maybe it was early appendicitis, before radiological changes became apparent. My third thought was that I needed to look more carefully at the rest of the scan. Problem? Dr. Keller appeared beside me as if summoned by my confusion, looking over my shoulder at the screen. His appendix looks completely normal, I said, hearing the frustration in my own voice. Then it's not appendicitis, but everything else suggests it is. The location of pain, the physical exam, McBurney's point tenderness, positive rebound, positive Rovsing's, positive psoas, the labs showing infection and inflammation, it all fits. CT is the gold standard, Dr. Reyes. Sensitivity and specificity both above 95% for appendicitis. If it's negative, it's negative. She leaned closer to the screen, her reading glasses sliding down her nose. What else do you see? Don't just look at what you expected to find. Look at what's actually there. I scrolled through the images again, this time forcing myself to look more broadly at the entire abdomen rather than focusing solely on the appendix. Liver looked normal, no masses, no signs of cirrhosis. Spleen normal size and density. Kidneys normal, no hydronephrosis, no stones visible. Gallbladder unremarkable, no wall thickening or stones. Pancreas normal. Bowel loops. Wait. I stopped scrolling and zoomed in on a particular slice. There, in the terminal ileum, the last section of the small intestine before it connects to the large intestine at the cecum, was something abnormal. There's wall thickening in the terminal ileum, I said, pointing to the area on the screen with the mouse cursor, and some surrounding inflammatory changes. Fat stranding here in the mesentery, and what looks like several enlarged mesenteric lymph nodes. Good catch. What does that suggest to you? My mind raced through differential diagnoses, mentally cataloging the causes of terminal ileum inflammation. Crohn's disease? Infectious enteritis like Yersinia or Campylobacter? Meckel's diverticulum with inflammation? Or? I stared at the image, trying to see what she was seeing. The wall thickening was focal, concentrated in one area, not the diffuse pattern typical of inflammatory bowel disease. There was enhancement with the IV contrast, suggesting increased vascularity or inflammation, and the surrounding inflammatory changes seemed localized rather than extensive. Appendicitis can occasionally present with a normal-appearing appendix if the inflammation is very early, or if there's a retrocecal appendix that's difficult to visualize completely, I said hesitantly. But this doesn't look like that pattern. The appendix itself looks normal, and this is clearly a different area of pathology. No, it doesn't fit that pattern. Look at the bowel wall itself more carefully. What do you see? I zoomed in further on the area of thickening, examining it with the kind of scrutiny I should have applied from the beginning. The wall of the small intestine was definitely abnormal, with irregular thickening and areas of enhancement. And there, within the wall itself, was something that made my breath catch. "There's a mass," I said, my voice barely above a whisper. "Small, maybe 2 centimeters in maximum diameter, but it's there. Within the bowel wall itself, not just inflammation." "Exactly. Now, what causes masses in the small bowel in a previously healthy 47-year-old male?" My stomach dropped as I ran through the possibilities, each more serious than the last. Lymphoma, carcinoid tumor, adenocarcinoma, gastrointestinal stromal tumor, metastatic disease from an unknown primary. All possible. But in someone presenting with acute abdominal pain that mimics appendicitis, in this specific location, what's most likely? I thought about what I knew about small bowel tumors from my limited experience. "Carcinoid tumor of the small bowel," I said slowly. "They're neuroendocrine tumors, relatively rare overall, but they have a strong predilection for the terminal ileum and appendix. They can present with intermittent abdominal pain from partial obstruction or from the mesenteric desmoplastic reaction they cause. And they're often found incidentally during surgery for presumed appendicitis. And they're frequently missed, Dr. Keller added, her voice taking on that particular teaching tone that meant this was an important lesson, because clinicians assume appendicitis based on the clinical presentation and stop looking once they've confirmed or ruled out that specific diagnosis. You could have stopped at normal appendix, assumed you were wrong about appendicitis, and sent him home with a diagnosis of viral gastroenteritis or non-specific abdominal pain with instructions to follow up if symptoms persisted. Instead, you kept looking at the scan. Why did you do that? "Because something didn't fit," I said, thinking about it. "The presentation was too classic for appendicitis, too many positive findings on exam. It didn't make sense that the CT would be completely negative." "Exactly. When something doesn't fit, when your clinical gestalt tells you something is wrong but the expected answer isn't there, that's when you need to look harder. Look broader. Consider other possibilities." She straightened up from the screen. "You need to call surgery immediately. And you need to tell Mr. Garrett that his case is significantly more complicated than we initially thought." My heart was pounding, adrenaline coursing through my system. This wasn't routine appendicitis anymore. This was potentially cancer. A tumor that could have been growing silently for months or years, finally causing symptoms severe enough to bring him to the emergency department. "How do I tell him?" I asked, suddenly feeling very young and inexperienced again. "Honestly, clearly, without unnecessary speculation or doom and gloom predictions. You tell him what you see on the imaging and what it might mean, and you explain that surgery will give us definitive answers. You acknowledge the uncertainty while providing a clear path forward." She paused, her gray eyes holding mine with an intensity that made me pay attention. "And Dr. Reyes, this is why we do imaging. This is why we don't just assume based on clinical presentation, no matter how classic it seems. You could have sent him home with antibiotics thinking he had early appendicitis. You could have admitted him for observation with plans to repeat imaging in 12 hours. Instead, you found something that could be life-threatening if left undiagnosed. That's good medicine. That's what being a careful physician looks like." I stood outside Bay 7 for a long moment, gathering my thoughts and steadying my nerves. This was the part of medicine they didn't prepare you for in medical school, or at least not adequately. The lectures covered diagnosis, treatment, pathophysiology, pharmacology, but they didn't teach you how your hands would shake slightly when you had to tell someone that what they thought was a simple problem might actually be cancer. They didn't teach you how to deliver potentially devastating news while maintaining hope and avoiding unnecessary panic. They didn't teach you how to sit with a patient's fear and not let it overwhelm your own ability to think clearly. I took 3 deep breaths, a technique one of my professors had taught me for managing acute stress, and walked in. Thomas Garrett was lying in bed, his eyes closed, his face drawn with pain and fatigue. The harsh fluorescent lights made him look older than his 47 years, highlighting every line of stress and exhaustion. When he heard me enter, he opened his eyes and attempted a weak smile. "Doc, please tell me you found something simple and fixable. Tell me I have appendicitis and you're going to cut it out and I'll be home in 2 days eating pizza and watching football. I pulled up a chair beside his bed, deliberately sitting so we were at eye level. That was something Dr. Keller had taught me during my first week. Never deliver serious news while standing over a patient. It creates a power dynamic that makes difficult conversations even harder. Sitting equalizes the relationship, makes it a conversation between two people rather than a pronouncement from on high. Thomas, I need to talk to you about your CT results, I said, keeping my voice steady and calm, even though my pulse was racing. His smile faded immediately, replaced by apprehension. That sounds ominous. Your appendix looks completely normal on the imaging, so this isn't appendicitis. But you said, I know, and based on your symptoms and physical exam, appendicitis was the most likely diagnosis. Everything pointed to it, but the CT tells a different story. So what is it? What's wrong with me? We found an abnormality in your small intestine, specifically in a section called the terminal ileum. There's thickening of the bowel wall and what appears to be a small mass, about 2 centimeters in diameter, embedded in the intestinal wall itself. He stared at me, his face going pale. A mass? You mean like cancer? This was the moment where I had to be honest while not destroying hope. The moment where every word mattered. We can't say for certain without further testing and tissue biopsy. It could be several different things. A benign tumor, an area of chronic inflammation mimicking a mass, or yes, possibly a malignancy. The most common tumor in this specific location would be something called a carcinoid tumor, which is a type of neuroendocrine tumor. Is that cancer? Carcinoid tumors exist on a spectrum. Some are completely benign. Some are low-grade malignancies that grow very slowly and rarely spread, and some are more aggressive. But we won't know what we're dealing with until we can get tissue for pathology. That means we need a biopsy or surgical removal so the pathologist can look at it under a microscope. Jesus Christ. He ran a hand over his face, and I could see it trembling. I came in thinking I had appendicitis. Something simple. Something they'd fix with a quick surgery and I'd be back to work in a week. Back to normal. I know, and I'm sorry this is more complicated than that. I wish I had simpler news to give you. So what happens now? I'm going to call our surgical team. They'll come down to examine you and review the imaging themselves. Depending on what they see and their clinical judgment, they'll likely recommend exploratory surgery, going in to directly visualize the mass, possibly remove that section of bowel, and send tissue to pathology for definitive diagnosis. Surgery. Tonight? Possibly. Or they may want to do additional imaging first. An MRI with special protocols, or a specialized CT with different contrast timing. I won't know their recommendation until they evaluate you. But Thomas, I want you to understand something important. Finding this now when the mass is small is actually good news. If this is a tumor, catching it early dramatically improves outcomes. He nodded slowly, his hands gripping the bed rails with white-knuckled intensity. And if it is cancer, if it's one of those carcinoid things, what's the prognosis? Let's not get ahead of ourselves with speculation. We don't know what this is yet, but I can tell you that carcinoid tumors, even when malignant, often have much better prognoses than traditional cancers if caught early. They tend to grow slowly, and surgical removal can be curative if the tumor hasn't spread to other organs or lymph nodes. The 5-year survival rate for localized small bowel carcinoid tumors is over 90%. 90%, he repeated, latching onto that number like a lifeline. But we need to know what we're dealing with first. One step at a time. My wife, he said suddenly, his voice cracking. I need to call my wife, Linda. She's going to want to be here. She's going to be terrified. Of course. There's a phone right there on the bedside table, or you can use your cell phone if you have it with you. And Dr. Reyes? He looked at me directly, and I saw raw fear in his eyes now, undisguised and vulnerable. If you hadn't looked at that CT so carefully, if you just confirmed the appendix was normal and sent me home with instructions to follow up with my primary care doctor if the pain didn't get better, would anyone have found this? The honest answer was complicated. Eventually, yes, but it might have been later, after more symptoms developed. Obstruction, bleeding, more significant pain. And depending on the type of tumor, delayed diagnosis can mean the difference between a small, localized tumor that's easily removed and a larger tumor that's spread to lymph nodes or other organs. So you might have saved my life by being thorough, by not just accepting the easy answer. I found something that needs to be addressed. That's all. That's not all. His voice cracked with emotion. I said you weren't a real doctor. that I wanted someone with experience, someone who knew what they were doing. And you found something that someone less careful might have missed. Something that could have been overlooked if you just confirmed appendicitis wasn't there and moved on to your next patient. Any competent physician would have reviewed the entire scan, maybe, but you're the one who did it for me, and I'm grateful. I'm terrified, but I'm grateful. Does that make sense? Yes, it makes perfect sense. I left him to call his wife while I paged the surgical service, stepping out into the hallway where the noise of the emergency department provided a strange kind of cover for the emotional intensity of what had just happened. My hands were shaking slightly as I dialed the number for the surgical service. Not from nervousness about the case itself or uncertainty about my findings, I was confident in what I'd seen on that CT, but from the weight of what I'd found, the weight of being the one to discover something that would fundamentally alter this man's life trajectory, for better or worse. This man's life might genuinely have been changed by my decision to look beyond the appendix, to examine the entire scan rather than stopping once I'd ruled out my primary diagnosis. Dr. James McKenna, the surgical attending on call, answered on the second ring. His voice was brisk and professional, the tone of someone accustomed to emergency consultations at all hours, someone who'd been paged out of dinner or sleep or family time countless times and had learned to compartmentalize. McKenna. Dr. McKenna, this is Dr. Reyes from the emergency department. I have a 47-year-old male with right lower quadrant pain, initially concerning for appendicitis based on clinical presentation. However, CT shows a normal appendix, but reveals a concerning 2-centimeter mass in the terminal ileum with surrounding inflammation and enlarged mesenteric lymph nodes. There was a pause. Send me the images. I'll take a look and call you back in 5 minutes. I transferred the CT to his account through the hospital's imaging system and waited, pacing a small circle in the hallway. Around me, the emergency department continued its relentless rhythm, ambulance sirens in the distance, a patient demanding to be seen immediately despite having waited only 20 minutes, a family speaking rapid Spanish in the waiting room, trying to understand what was happening to their loved one. My phone rang exactly 4 minutes later. Dr. Reyes, I've reviewed the images. That's definitely a mass, and the enhancement pattern is concerning. Could be carcinoid, could be lymphoma, could be a GIST, possibly adenocarcinoma, though that's less common in that location. Hard to say definitively without tissue. How's the patient clinically? Stable. Significant pain, but vital signs are completely normal. Labs show elevated white count to 16,200 and CRP of 45. No signs of perforation, no free air, no obstruction on the CT. Has he eaten recently? I checked the timeline in his chart. Last meal was lunch, about 8.5 hours ago. He had oral contrast about 90 minutes ago for the CT, but nothing else. Good. I'm finishing up a lap chola right now. Should be done in about 30 minutes. I'll come down to evaluate him then. In the meantime, keep him NPO. Nothing by mouth, not even water or ice chips. Start IV fluid resuscitation at 125 milliliters per hour. And let him know we're very likely going to take him to the OR tonight. I want to do a diagnostic laparoscopy to directly visualize this mass, possibly converting to open procedure if we need to do a formal bowel resection. Understood. His wife is on her way in. She's about 45 minutes out according to the patient. We can wait for her if he wants her here before surgery, but not indefinitely. This isn't an emergency in the sense that he's going to die in the next hour, but we also don't want to delay. If this is a tumor, we need tissue diagnosis. If it's something else causing acute inflammation, we need to address it. Either way, expectant management and wait and see isn't the right approach here. I'll let him know. And Dr. Reyes? Yes, sir? Good catch on this. Really good catch. A lot of people, even experienced ones, would have stopped at normal appendix and either sent him home with a diagnosis of non-specific abdominal pain or admitted him for observation with a plan to repeat imaging if symptoms worsened. You kept looking and found something significant. That's excellent medicine. That's the kind of thoroughness that saves lives. The praise felt simultaneously validating and overwhelming, like a weight settling onto my shoulders that I wasn't sure I was ready to carry. Thank you, sir. I appreciate that. See you in 30 minutes. Have him ready for my exam. I hung up and stood there for a moment, letting the reality of the situation fully sink in. I'd found something important. Something that could have been missed if I'd been less thorough or more willing to accept the easy answer, the convenient explanation that fit most of the facts, but not all of them. I returned to Bay 7 to find Thomas on the phone with his wife, his voice strained and tight as he tried to explain the situation in terms he barely understood himself. No, not appendicitis. They found something else. A mass, like a tumor in my intestine. They don't know what kind yet. Yes, I need surgery. Tonight, probably. Linda, I know this is scary. I'm scared too. Just drive carefully, don't speed. It's not worth having an accident. I waited by the entrance, not wanting to interrupt the private moment between husband and wife. Thomas must have seen me in his peripheral vision because he held up a finger. 1 minute. Okay, just get here when you can. Drive safe. Don't cry and drive at the same time. That's dangerous. I'll be here. I'm not going anywhere. I love you too. See you soon, baby. Okay. Bye. He hung up and looked at me with eyes that were wet but not quite crying. A man trying desperately to hold himself together. She's on her way, crying and trying to drive at the same time, which is terrifying. I told her to pull over if she needs to, but knowing Linda, she won't. The surgeon is coming down to examine you. Dr. McKenna. He's excellent. Been doing this for over 25 years. Teaches the surgical residents, known throughout the hospital for his technical skill and judgment. He reviewed your imaging and agrees that we need to investigate this mass surgically. How long until surgery? Depends on when your wife gets here and how backed up the OR schedule is. But Dr. McKenna wants to move relatively quickly. This isn't an immediate life or death emergency where we need to operate in the next 10 minutes. But it's also not something we want to wait days or weeks to address. The sooner we know what we're dealing with, the sooner we can make a treatment plan. Thomas nodded, absorbing this information with the stunned acceptance of someone whose reality had shifted dramatically in the span of an hour. You'll be there? During the surgery? The question surprised me. I'm an emergency medicine resident, so I won't be performing the surgery, but sometimes the surgical team allows interested residents from other specialties to observe complex cases. I can ask Dr. McKenna if I can scrub in to observe if you'd like. I'd like that. I'd like to know that you're there, watching, making sure. He trailed off. Making sure everything goes right? Yeah, I know that sounds stupid. Like you could stop anything if it went wrong during surgery. But just knowing you'd be there would make me feel better somehow. It doesn't sound stupid. It sounds human. And I'll absolutely ask Dr. McKenna if I can observe. Can I ask you something personal, Doc? Of course. You're young, probably younger than my son, who just turned 26 and finished law school last month. How do you handle this? Finding something like this, telling someone their whole life might be about to change, carrying the weight of potentially having saved someone's life or missed something that could kill them. How do you carry that weight and not break under it? It was a profound question, one I'd asked myself many times during sleepless nights after difficult shifts. Honestly, I don't know that I handle it well. I lie awake some nights replaying cases in my head, wondering if I missed something, if I could have done better, if I ordered the right tests or asked the right questions. The weight of responsibility, of knowing that my decisions directly impact whether people live or die, whether they suffer or heal. It's crushing sometimes. So how do you keep doing it? Because I also remind myself that this is exactly why I went into medicine. Not for the prestige or the salary. Trust me, residents are paid barely minimum wage when you calculate the hours we actually work. But because I wanted to help people in the most direct, immediate, tangible way possible. I wanted to find answers when people were desperate for them. I wanted to make a difference even when it's hard, especially when it's hard. That's what keeps me going. That's a good answer. A real answer, not the bullshit, polished response you'd give to someone you were trying to impress. You asked a real question. You deserved a real answer. Sarah appeared at the entrance with an IV bag of normal saline. IV fluids as ordered. And I brought him some ice chips even though he's NPO just to wet his mouth. The contrast left him really dry. Thank you, Sarah. You're wonderful. I know, she said with a slight smile, hanging the IV bag and adjusting the flow rate. Dr. McKenna called up. He'll be here in about 15 minutes. He said to tell you he wants you to scrub in on the case if you're interested. My heart leaped. Really? Really. He said any resident sharp enough to catch that mass deserves to see what it is firsthand. I looked at Thomas, who was smiling for the first time since I'd told him about the tumor. Looks like I'll be there after all. Good. That's really good. Thomas's wife, Linda, arrived 28 minutes later, breathless and tear-stained and carrying the sharp scent of anxiety that only intense fear can produce. She was a petite woman in her mid-40s with worry etched into every line of her face, wearing yoga pants and an oversized sweatshirt that suggested she'd been home relaxing when she got the call. She rushed to Thomas's bedside, and they embraced as much as the IV lines and monitoring equipment would allow, holding each other with the desperate intensity of people who'd just had their comfortable reality shattered. "I'm so scared," she whispered, loud enough for me to hear from where I stood respectfully by the door. "What if it's cancer? What if it's spread? What if we waited too long?" "Me too," Thomas admitted, his voice muffled against her shoulder. "But Dr. Reyes found this early. That's gotta count for something. That's gotta mean we have a chance." "Dr. Reyes?" She looked up at me with eyes that were puffy from crying during the drive. "That's me," I said, stepping forward with what I hoped was a reassuring presence. "I'm the emergency medicine resident who evaluated your husband tonight. Thomas told me on the phone that you found something the initial test didn't show, something everyone else might have missed. The CT ruled out appendicitis, which was our initial concern, but it showed an abnormality in the small intestine that needs surgical investigation. That's why we've called in Dr. McKenna and the surgical team." "Is it cancer?" she asked bluntly, needing to hear it from me directly. "We don't know yet. It could be several different things. The only way to know for certain is surgical exploration and tissue biopsy. But I want you to know that finding something like this when it's small, 2 centimeters, is significantly better than finding it when it's larger and has caused more serious symptoms. Thank you for being thorough," she said, her voice breaking again. "Thomas said you could have easily missed this, that you went above and beyond looking at his scans. I just did my job, Mrs. Garrett, but you're welcome." Dr. McKenna arrived shortly after, sweeping into the bay with the commanding presence that experienced surgeons often carry. Not arrogant, but confident in a way that immediately reassured anxious patients and families. He was a tall man in his early 50s with graying hair, kind eyes, and hands that looked surprisingly delicate for someone who regularly cut into human bodies. "Mr. Garrett, Mrs. Garrett, I'm Dr. McKenna. I'm the surgical attending on call tonight." He shook both their hands firmly, making direct eye contact with each of them in turn. "Dr. Reyes has filled me in on the case, and I've personally reviewed all your imaging. There's definitely an abnormal mass in your small bowel that needs investigation." "What exactly will you do?" Thomas asked, his voice steadier now that a plan was forming. "Dr. McKenna pulled up a chair and sat down, putting himself at their level. Another sign of an experienced physician who understood that delivering information was as much about comfort as content. "We'll start with diagnostic laparoscopy. That means making several small incisions, each about a ½ inch long, and inserting a camera along with specialized instruments to directly visualize your abdominal organs. If we can safely biopsy the mass laparoscopically, we will. If we see something that requires more extensive work, like removing a section of bowel, we may convert to an open procedure, which means a larger incision down your midline. How risky is this? Every surgery carries inherent risks: infection, bleeding, adverse reaction to anesthesia, injury to surrounding structures, blood clots, pneumonia. But bowel surgery is something we do very regularly, and I've personally performed hundreds, if not thousands, of these procedures over my career. If we need to remove a section of your small intestine, what we call a bowel resection, we cut out the abnormal portion and reconnect the healthy ends with sutures or surgical staples. Your body is remarkably adaptable. You have about 20 feet of small intestine, and you can lose several feet without significant functional impairment. And you'll be able to tell what the mass is during surgery? We'll send tissue for frozen section pathology during the operation. That gives us preliminary results in about 20 to 30 minutes. Basically a rush job by the pathologists to give us information while you're still on the table. They freeze the tissue, slice it very thin, stain it, and look at it under a microscope. That will tell us if it's benign or malignant and guide our decisions about how much tissue to remove. But definitive pathology with specific tumor typing and grading takes 3 to 5 business days because they need to do more detailed microscopic analysis and sometimes special staining techniques to identify exactly what kind of cells we're dealing with. "What if it's cancer?" Linda asked, her hand gripping Thomas's tightly. "Then we remove what we can see, obtain what we call clear surgical margins, meaning we cut into healthy tissue beyond the visible tumor to ensure we've removed it all, and we check the surrounding lymph nodes for any signs of spread. You'll then follow up with oncology for staging scans to see if there's disease anywhere else in the body, and they'll discuss whether additional treatment like chemotherapy or radiation is needed. But let's not borrow trouble before we know what we're dealing with. Many small bowel masses turn out to be benign or low-grade malignancies with excellent outcomes. Dr. McKenna spent another 20 minutes with them, explaining the procedure in meticulous detail, outlining every possible risk and complication with the thoroughness required for informed consent, answering their questions with patient clarity. I stood to the side, observing a master at work. The way he balanced honesty with hope, acknowledged fear without being consumed by it, used plain language instead of medical jargon, maintained eye contact, projected competence without arrogance. This was what I wanted to become. Not just knowledgeable, but able to connect with patients in their most vulnerable moments, able to guide them through terrifying situations with compassion and clarity. "We'll take excellent care of him, Doctor," McKenna assured Linda as they prepared to transport Thomas to the pre-op area. "He's in very good hands and Dr. Reyes will be scrubbing in to observe. I like having sharp residents in my OR because they keep me honest and ask good questions." I blinked in surprise at the public endorsement. "Sir, I'm honored. You found it, you should see what it is," he said matter-of-factly. "Besides, this is an educational hospital. You might learn something about surgical technique that'll make you a better emergency physician. Understanding what we do and how we think helps you know when to call us and how to prep patients appropriately." As the transport team arrived to take Thomas upstairs, he reached out and grabbed my hand one last time. "Thank you, Dr. Reyes, for looking harder when you could have stopped, for not giving up when the easy answer didn't fit, for being exactly the doctor I needed even though I was too stupid to see it at first." "You weren't stupid. You were scared. There's a difference." "Still, thank you." They wheeled him away, Linda walking alongside the gurney holding his hand, and I stood in Bay 7 feeling a complex mixture of emotions I couldn't quite name. Pride in having found something important, fear that I might have missed other things, anticipation about observing the surgery, exhaustion from the emotional intensity of the past few hours. "Dr. Reyes," I turned. Dr. Keller stood in the doorway, arms crossed, but her expression was softer than usual. "You did well tonight. Very well. You handled a difficult patient with professionalism. You didn't let his initial rejection shake your confidence to the point of missing something important. You looked at that scan with the thoroughness every scan deserves, and you're about to see exactly what your diligence found. That's good medicine. That's what this job looks like when it's done right. Thank you. That means everything coming from you. Don't let it go to your head. You'll make plenty of mistakes in your career. We all do. But tonight, you got it right. Remember this feeling. Hold on to it for the nights when you get it wrong and question whether you belong in this profession.